Hello, everyone, and thank you for joining us for our webinar today. My name is Trina Boyko, and I'm a content writer at Brain Tumor Foundation of Canada. I'm glad to be here with you for our webinar on When Trauma Meets Brain Tumor with Christine Fader. So we'll start with our land acknowledgement. We acknowledge that Brain Tumor Foundation of Canada is located on the traditional territory of the Anishinaabe, Haudenosaunee, Attawandaron, and Wendat peoples. We honor and respect the history, languages, and culture of the diverse Indigenous people who call this territory home. We move forward with a profound sense of gratitude and respect for the land and its original caretakers, and we are grateful to have the opportunity to work and live in this territory. I'd like to welcome you all to today's webinar. Our webinar series is designed for anyone impacted by a brain tumor, whether patients, survivors, caregivers, and volunteers, as well as healthcare professionals and researchers seeking to expand their knowledge. Our sessions explore a wide range of topics, including neuro-oncology, neurosurgery, research advancements, psychosocial oncology, mental health, and caregiver support. So just a note about language before we begin. At Brain Tumor Foundation of Canada, we're committed to using language that is inclusive of everyone affected by a brain tumor. Brain tumors affect everyone differently, and people living with both malignant and non-malignant brain tumors can experience significant changes. Some topics discussed in our webinar are informed by oncology research, and you may hear words such as cancer or survivorship. These terms reflect the evidence being presented and are not intended to exclude or diminish the experiences of anyone living with a brain tumor. While some information may not apply to every diagnosis, we hope the principles shared will be valuable to the broader brain tumor community. A few housekeeping notes before we start. The webinar will be recorded, and a link to the recording will be shared with all registrants within 1 week of the webinar. The recording will also be available on our website at braintumor.ca. We will have dedicated time at the end of the presentation for questions and discussion. We ask that you please send your questions through the Q&A function and not through chat. And also please note we're unable to answer very specific questions. We encourage you to contact your health team for specific advice. Along with the webinar recording, any resources shared during the webinar will be emailed to all registrants within a week. So before we get into our topic, we're going to share a quick poll so we can get a better understanding of who's joining us today. We'll put the polls up now, so if you could please fill them in, we would appreciate it. Wonderful. Thank you so much for filling out our polls. I'd like to introduce today's speaker. Today we have with us Christine Fader. Christine is a caregiver advocate, writer, and speaker dedicated to advancing trauma-informed cancer care and ensuring caregivers' voices are heard and valued. She volunteers as a patient experience advisor with Ontario Health Cancer Care Ontario, the Southeastern Ontario Cancer Program, and the Lung Health Foundation. Drawing on lived experience as a caregiver and someone who has lived with seizures for nearly 40 years, Christine brings insight and compassion to conversations about caregiving, grief, and patient-centered care. Thanks, Christine, for being here today.
Thank you very much for having me. My first challenge is always to share my slides, so I'm going to attempt to do that now. So please bear with me while I work on that part of things. Right. Mhm. Okay, are you seeing the presentation?
Yes, Christine.
Great. Okay. So thank you very much for having me today. As was mentioned, my name's Christine Fader, and I have a little bit of experience with brain tumors, both from my own life and from the life of my husband, Michael. As was mentioned, I was diagnosed with a non-malignant brain tumor when I was 18 years old because of the seizures that I had started having. And after the first CT scan, the team said, we think you have a benign, or what they called at the time, a benign or non-malignant brain tumor, but we're going to watch it and see what it does in the next few months. Because right now it's not doing a huge amount of damage, but it might. So at the next CT scan, 3 months later, they told me, oh, actually, there's no tumor there. So that was sort of an interesting, sort of weird place to be in for a few months of my life. But yes, luckily I ended up not having a brain tumor, although I have been dealing with seizures ever since. And then my husband, Michael, was diagnosed in 2018 with the first of two primary cancers. So he was diagnosed in 2020 with a different cancer that wasn't related to the first one. So that wasn't a spread of the first one. And as part of his second cancer, he ended up with 3 brain metastases or brain tumors. So I was sort of back in the brain tumor arena again. I just want to mention, I think we did in the publication for this, but I just wanted to mention that this session does include a little bit of reference to potentially disturbing topics, including physical and sexual abuse of children, foster care, residential training school, and child homelessness. And I always encourage people to do what's most helpful for you under the circumstances, and that might mean even leaving the session and consider seeking support afterwards. I am going to put up a couple of um, signposts for possible support for those who might need it. And I notice myself, even though I'm very familiar with this topic and my husband's story, I find that after I do these sessions, I often need to build in some time to just kind of recover from talking about some things that can be potentially upsetting. So please seek help if that's something that is useful for you. So as I mentioned, my husband Michael was diagnosed with the so-called good kind of throat cancer in late 2018. And as far as cancer diagnoses go, his team said, it's all good news. It's early stage. We think it's pretty curable, but you probably won't like how we get you there because throat cancer treatment impacts people's breathing and swallowing and talking and taste, and in my husband's case, his beard. So there are lots of sort of impacts, lots of patient burden, as they call it. So he was prescribed 35 radiation treatments to cure the throat cancer. And that means every day for 7 weeks, every weekday for 7 weeks, rather. And the way that they do this with head and neck cancer, and I know that some of you, if you've had brain radiation, will be somewhat familiar with this type of mask, although yours might be a little slightly different. But for head and neck cancer, the mask in his case went from the top of his head down over his shoulders. And as you may know, it's customized to each patient. So there's some pliable mesh that's placed over the patient's face, and then it molds to their features specifically so that when they go on the table, the mask is bolted to the table, and it ensures that the patient doesn't move during the treatment, which is really important, of course, because you want the beam to go where it's supposed to go at the cancer and not damaging other sorts of tissues. So when they made the mask, Michael initially told the radiation therapist that he was claustrophobic. He kind of shorthanded his background trauma to claustrophobia. And I think that's a pretty common thing that radiation therapists hear, because, you know, a mask like this is probably not comfortable for everybody. And being so tightly sort of pressed to the table is also not comfortable for people. So that's something that they heard, I think, fairly regularly. So I think the person who was building the mask on that first day for him very kindly tried to be distracting to him. And so she sort of chatted continuously to him while she was building the mask. But the problem was that claustrophobia was not actually the full story for my husband. So, but he made it through that mask building. He left the treatment room, looked completely normal, said goodbye politely and everything. And we walked out to the car. And as he took my hand, I noticed he was absolutely vibrating and shaking. And he barely made it to the car and kind of fell inside and said, "No way, I am not doing that." And those were the last words he said for about 4 hours. I had never seen him in that state before. So the prospect of doing that 35 times, even though those treatments I think are around 10 to 12 minutes, was just something he could not figure out how he could possibly survive. So I also want to just talk a little bit first about what is trauma. And I borrowed this diagram from researchers who talk about what trauma is. And I'm not a trauma expert. I always want to clarify that. I'm really looking at this topic from our lived experiences, my husband's lived experiences, and my experiences supporting him around his trauma, before and during his cancer and end of life. And but trauma can take all kinds of different forms. And my husband never would have called it trauma. I would never have heard that word come out of his mouth. So lots of people who might have trauma won't necessarily identify it as trauma or describe it that way, but it includes all sorts of things. So mostly today, what we're going to be talking about is individual trauma. So the trauma that impacts a specific person from their life experiences. So that can include things like adverse childhood experiences, or ACEs as they're sometimes known. But it also includes interpersonal trauma, so trauma between people, and then collective trauma. That could be something like coming from a war situation, in a country, or the COVID-19 pandemic is sort of a fairly recent collective trauma I can think of. But it includes all sorts of phobias: transphobia, homophobia, ableism, sexism, human trafficking, sexual harassment, medical trauma, all sorts of different things. And people can be coming into an illness with trauma that's pre-existing, and then the illness itself or the treatment for it can also actually cause trauma. So there's sort of all of those things in the spectrum of trauma. And as I mentioned, trauma is not a word that he would ever have used. And I also wanted to just mention, what does trauma look like? And if you're someone, or you're supporting someone who is a trauma survivor, you'll probably, realize or recognize this. And that is that sometimes when we were by ourselves and my husband was having an experience that was difficult, I saw the trauma in him. I saw the trauma in him that day that he fell into the car and said, "No way, I'm not doing this." But lots of other times, there was no evidence of trauma. He was a very confident person. He was a former military skydiver. He worked in search and rescue. He was always climbing things and jumping off things. And so he wasn't a timid person in terms of his physicality, but also in terms of his personality. He was also extremely kind and the most considerate person I've ever met in my entire life. He was the first person to make a snow angel every winter. He always ran out in the first snow and made a snow angel. He also stomped lots of hearts in the snow for me. So this is a picture of one that he did while he was quite ill, actually, with his second cancer. He loved to collect rocks, and he loved to be the outdoors. He loved little children. He was a very affectionate and kind person. But he had he had difficulty with certain things, and he did things every day of his life to keep his past trauma at bay. So when he went in for that mask fitting, it was it he wasn't looking forward to it, but I don't think he realized the extent to which it would activate or reactivate some of his past experiences. And I try to use the word activated as opposed to triggered. I know we're comfortable with the word triggered in our world, especially talking about PTSD and trauma. But there are people who are survivors of gun violence, and I think triggered is actually a very difficult word for them. So I try to use the word activating and reactivating when I talk about some of his symptoms. So, he did all these kind of quite daredevil and brave things. He'd worked hundreds of meters underground in a mine. He'd been shot at by a sniper, and he'd survived all this trauma. So why was the mask such a deal breaker? And I always tell the sort of shortened version of his story, which is that Michael was more of an expert than most people in surviving very, very difficult things. In fact, when he first was diagnosed with cancer, he said, "Cancer is by far not the worst thing to ever happen to me. I can totally survive this. I can totally manage." But when he went to get that mask built, his past experiences came back in a really big way and interfered. So before the age of 13, his father died when he was 7. They lived in a little Northern Ontario village, and his father died unexpectedly from a tonsillectomy when Michael was 7, and he was the oldest of 5 children. So his mother had 5 children under the age of 7 in a little village, and so she really had to kind of get married very quickly to survive. And unfortunately, the person that she married was extremely abusive. So Michael was the oldest child, and so I think he tried to be the sort of barrier between himself and his siblings. So he suffered a lot of abuse at the hands of his stepfather, and was removed finally from the home and put into foster care, where he was further abused. And so he kept running away from foster care. And in those days, you could be charged with truancy as if you weren't going to school, and sentenced as a juvenile delinquent because he was running away from foster care. So he was sentenced to what they called a residential training school, a reform school in those days, a now notorious school called St. Joseph Training School in Alfred, Ontario. And he was sentenced there and sent there far away from his home, and suffered further terrible abuse there. When he finished his sentence, he was told his mother had too many children and he shouldn't go home. So he was 12 and a half. So he did go back to his village, but he lived under a railroad trestle bridge for an entire Northern Ontario winter with a sleeping bag that he found in the woods. And he was starving and freezing, and he had untreated physical and sexual abuse injuries. So he had been through a lot in the early part of his life and had managed to get beyond it, move away, deal with it. He'd never been treated, but he learned to sort of deal with a lot of his symptoms, as I said, by doing specific things every day to avoid situations that were activating or to prevent things from occurring. But the mask activated really horrific memories of being choked and smothered and restrained, as I'm sure you can imagine. So he said to me when we got home, when he could speak again, he just reinforced, "I absolutely can't do that. I cannot do that." And he said, I don't know how to survive doing that 35 times. And there were no kind of obvious signs in our cancer center or doctor's offices that Michael could ask for help, that it was okay to disclose something like this, or how much of it he might have to disclose to get help. But because I used to hire physicians, and I worked with medical students for years, and I have people in the hospital system that work higher up, I know the systems and I wasn't intimidated by them. So I said to him, I think we should try to talk to people about how to manage this somehow. And after about 2 or 3 days, he finally agreed. He was really nervous, and he said to me, "How much do I have to tell them? And, is it okay to tell them this?" And he said to me, "Honestly, if it weren't for you, if I didn't want to stay alive for you, I would run away and never come back." And I do this session for oncology staff, and mostly actually. And I've had lots of people say to me, "Wow, I've had patients who have called and called and called, and they've never responded, or they've left a clinic and never come back. And I never really knew what happened. And this is a possible idea of what might be going on. So we requested a private conversation with the team, and we sort of chatted beforehand about what were we going to say, how much were we going to tell them. And he was comfortable saying, I'm a survivor of child abuse. You don't have to say that if you're in a similar situation. You can simply say, I've had trauma and I need help with X or Y. He decided that he wanted to disclose that he was a child abuse survivor with a choking and smothering history. And that's why this was so very difficult. He wasn't like other mask patients who might be having a claustrophobia reaction. And because they had offered him anti-anxiety medication, and he said, absolutely not. I cannot take any medication that will make me lose any control. I have to stay in complete control. I have to be absolutely sober and in charge of things. So the anti-anxiety medication that they often offered to people just wasn't going to work for him. So he asked the staff to just not talk to him at all during the procedures. When he was a child and he was in these horrific situations, he told me that he used to escape by going out of his body in his mind, out the top of his head, out the top of his house, and he would fly over the rooftops around in the sky. And so the fact that he became a professional skydiver later was always incredibly poignant to me, because that was a place where he felt the most himself and the most free. And he was able to do that on his own terms as an adult. But as a child, he would always escape this way. So he said to the team, I need to kind of go into my space, my escape space during this treatment. So please don't talk to me at all when you're setting me up on the table. Don't talk to me during the procedure. Don't talk to me when you're getting me out of the mask. Just don't talk to me at all. And I'll try to go to my place where I can cope with this. So he did manage to complete the treatment 35 times. And I was in the waiting room 35 days in absolute agony, knowing what he was, a little bit about what he was going through in that room. So it was pretty horrific, and it was difficult because people sort of thought we had sort of the good version of cancer and it was pretty curable and it was kind of good news, but they didn't know but this extra layer of stuff that was happening at the same time that was extremely difficult for him and extremely difficult for me to witness. But he didn't look traumatized on the surface. So while he was undergoing this, I'm an educator. I used to work at Queen's for 20 years as a career advisor. So I started thinking, is this happening to other people? What can I do to make this better somehow? I couldn't make it better for him individually, but what could I do? And I found in 2022, actually, so this is more recent data, 34% of Canadian adults report being survivors of childhood sexual or physical abuse. And I'm obviously privileged because that number was large enough to shock me. I was surprised it was that high. And that doesn't include other kinds of trauma. And I also found a study about cancer patients. It was breast cancer patients, I believe. And it said that cancer patients with a previous history of trauma have an increased rate of getting the disease in the first place. And they tend to have lower treatment compliance, bail out of treatment more often, don't complete it, and they have worse survival and outcomes because of that. And I thought, that is not okay. Yeah, I'm not okay with that. And then that 34% of Canadian adults does not include other adverse childhood experiences. And there are large longitudinal studies done on adverse childhood experiences, or ACEs. And there was originally a list of 10 childhood experiences that can impact children later in life from a health perspective. And my husband had all of the original 10 items on the list. So it includes things like having a parent in jail and living in a house with substance abuse and being abused and various kinds of things. So he had all 10 of those things. And there are studies that show that if you have more than 6 untreated childhood experiences that are adverse, you have a much higher rate of serious disease. So 290% increased rate of cancer, 300% increased chance of heart disease. So there's some serious implications if you're not treated for these adverse childhood experiences or they're prevented in the first place. And then it also doesn't include that 34%, doesn't include other trauma in childhood or since childhood, or it doesn't include acquired healthcare trauma. So I thought, wow, in a cancer center, there are potentially lots and lots of patients that are coming in with pre-existing trauma or acquiring trauma during their treatments. And it's not rare. It's just not rare. And therefore we need to really talk about it, I believe. And then this is a chart from the US, but similar in Canada. There are lots of studies that show that people who identified as members of marginalized populations have a much higher rate of adverse childhood experiences in general. So racialized people and Indigenous people, lesbian, gay, bisexual, transgender, two-spirit people, people who are unemployed or underemployed, people with disabilities, all kinds of people with lower education. So those kinds of factors also increase the chance that someone is likely to have experienced trauma. And not all trauma is going to impact their illness, but it may. So this is a chart that I show just to give a small sense of some of the scope of the interactions that we had with the healthcare system during Michael's two cancer. So he got his first cancer in 2018, finished treatment in 2019, got his second cancer in 2020, and died at the end of 2022. So during that time, he had lots of different kinds of treatment, which we were very grateful for. But also, all of these experiences meant that there were thousands of interactions where sometimes they went really, really well. I mean, people were overwhelmingly kind and supportive and helpful, and so busy, so busy. So I have a lot of empathy for healthcare providers. But also there were lots of small things that cumulatively kind of added up over time to cause damage or make things more difficult for Michael and for me. Unfortunately, at the end of Michael's life, he was paralyzed from the ribs down from a spinal tumor that was pressing on his spinal cord. So he spent the last 4+ months in the hospital. We didn't have enough home care or hospice or nursing care in our community at the time for him to come home, which was where he really wanted to be. But unfortunately, that was not possible. And so he spent the last part of his life in the hospital. Where they also discovered 3 brain tumors. And that's, I think, very challenging for everybody, but particularly challenging for someone who had institutional abuse history. So, Michael had been attacked many times in the night as a child. And so now he was spending the night in the hospital with different roommates, different staff coming in, people waking him in the middle of the night without him knowing about it. Lots of situations where it was extremely difficult and had the added layer of his trauma history on top of being very ill and being in the last part of his life. So, one of the things I always talk to healthcare providers about is it's small issues that have a big impact, especially over time and cumulatively. And so I try to give them some ideas about small things they can do that can actually hopefully prevent some of these negative experiences and reactions, without having to send them for long amounts of training, which I think is great, but lots of healthcare providers are not going to be able to do that. So one of the things that I noticed when Michael was going to clinic appointments, when he was still, we were still at home and he was coming in for appointments and treatments, was that he had trouble, and I've heard this is common with people with trauma, he had trouble with answering more than about 2 questions in a row from the oncologist. So, it's really normal when you go in for a doctor's appointment that someone asks you questions about your symptoms and how you're feeling and maybe how the treatment is going, if you're having any side effects. And he would, as many trauma survivors do, he would completely get flustered and sort of go into a post-traumatic stress disorder or post-traumatic stress reaction in those circumstances, even though it was just a, boring conversation. And so I really needed to be in his appointments with him to help him feel calm. So just being there really helped him feel like he was safer. And but also when he started to be flustered, he was okay with me jumping in and kind of explaining the symptoms, for example, he'd been having, because he would either shut down and get flustered and confused, or he would actually make things up. And he didn't do it intentionally. He wasn't maliciously lying, but he would just start coming up with answers because he was so flustered and sort of traumatized. So it was really important that I kind of be there to help with that, and that was difficult because it was still in the COVID echo. So I had to get some special permissions to be in some of his appointments, in his clinic appointments with him. Not some of them, all of them. And I think the other thing to notice or to mention is that we only disclosed about his trauma past that one time with the radiation therapy team. We never disclosed ever after that. So that was very early in 2018. He died in 2022, and that was the only disclosure. So you do not have to disclose repeatedly. There are ways that you can sort of navigate through some of this, and there are communication systems that need work in healthcare situations and hospitals, in my opinion, that would help with sort of sharing information with your permission, that would help all the different providers that are having contact with you manage and understand a little bit about what you need. So as I mentioned, the last part of Michael's life was very difficult. Unfortunately, the cancer that he had lung cancer, was a second cancer, and it was completely removed. He had one tumor. It was completely removed with surgery. But they found one lymph node that had cancer. So he ended up going through chemotherapy. And while he was doing chemotherapy, he started getting a really bad pain in his rib. And it was discovered after chemotherapy was finished and they did the scan that he had a tumor that had metastasized to his kind of rib level spine. And that was really the only cancer, visible cancer, he had for most of his lung cancer journey, was this tumor at his T8 and T7 eventually vertebrae, sort of right where your ribs are, right where your core is, right where you move. And so even though it was a very small amount of cancer, his oncologist actually described his cancer as very low volume, very bad location cancer because of where it was. It was in a spinal column. It caused excruciating pain for almost 2 years before he died. And unfortunately, he was also not responsive. His body didn't respond to all the really extreme medications that they usually give people in pain. So he struggled immensely, and they struggled immensely trying to help solve the problem. And then, of course, as a newly paralyzed person, anybody who's newly paralyzed, I'm sure, feels incredibly vulnerable. And it's a very challenging thing to go through. But for him, a person who was always prepared, he always carried his Leatherman tool on his belt so he could save us, so he could save me. He would go into every room, every restaurant, every movie theater, and he would know exactly where all the exits were immediately. He had to face the exits in restaurants, for example. So he was always very prepared and hyper vigilant about safety and knowing what was going on. So to be in a situation where he didn't know the staff, he was paralyzed, he couldn't run away, it was incredibly difficult for everyone. So every person coming in to do intimate care was really challenging. As I said, new roommates, new staff. And I sort of tried to run around and help part the waters and mitigate some of the things. So one of the things that I talked to the staff about, without revealing his background, but I would say, could you please make sure that you touch his leg or his foot, or actually when he was paralyzed, his arm, because he could feel there. But before you touch him, use your voice to warn him. Because I was really afraid, and it was a very reasonable fear, that if someone touched him in the middle of the night to do normal things like vitals and check he was okay, give him medication, if they touched him without warning him, he might have hit them or reacted extremely strongly. So I was trying to run around and talk to all the patient care assistants and the nurses and the physicians and residents and fellows, and try to make sure everybody knew like a couple of things. And I didn't divulge why. I think his palliative care doctor, his lead palliative care doctor, knew that he was a an abuse survivor, but nobody else really knew the specifics. They just knew I tried to help them understand that there were things that were important for him. And I remember last fall when I was doing a session for oncology nurses, that one of the nurses came up to me afterwards and she said, "Oh my goodness, I realize as I'm talking to you that I touch my patients all the time. I try to reassure them. I put my hand on their hand or I put my hand on their leg, and I'm doing it out of kindness and as to reassure them." But she said, "I'm realizing I should not be doing that without asking for permission first." So she had a revelation from that story. And this is an adapted chart from the Alberta Health Services. They have a trauma training initiative, which I highly recommend. I think it's about 4 hours worth of content that you can go in and out of, and it's open to the public. So if you're interested or you want to refer someone, this is a place where you can get a bit of knowledge about trauma. And so they have this chart that I've adapted about signs of trauma, but I've adapted it for signs of trauma in Michael. And I also just wanted to reinforce as well that you might not see signs of trauma at all. So his staff, especially when he was an inpatient, would always say, "Oh, he's so polite, he's so kind, he's in such agony, but he's always so kind." And they didn't see someone who was timid or afraid or violent or any of the sort of stereotypes that sometimes people think about when they think of trauma survivors. But certainly for him, as I mentioned, he had extreme hypervigilance. His whole life was about hypervigilance and guarding against all kinds of different potential situations that would be difficult for him or for me. Unfortunately, in cancer and in serious illness, like many of you may have, long used protection strategies that he'd always used weren't possible. So one very simple thing that he always did was, because of his choking history, he never wore a shirt that wasn't a V-neck. It always had to have a V-neck. And he couldn't wear a tie really unless it was very loose. And unfortunately, a lot of those strategies that he used constantly in his daily life to manage as an adult weren't possible in the healthcare system. They just, and especially as an inpatient, but even before that, they weren't possible. As I mentioned, sometimes he would present as very confused, or couldn't remember things, or dissociated. Some people manifested with irritability or anger or unintentional reactions. So Michael had a situation where he was coming out of anesthesia, and it's actually pretty common for people to be quite confused and delusional. And he actually hit somebody, and he was absolutely devastated that had happened. And it was not his fault, but it was a reaction to something that he just had no control over. So it can happen sometimes. The other thing that I noticed about him, which I think is also common in many people with trauma, is that there's a difference in how they report pain symptoms or physical symptoms. So Michael, in his case, he seriously underreported pain. I remember one time we were in the clinic and we were seeing the palliative care team, because he was seeing them for 2 years trying to get his pain under control. And he was kind of curled in the fetal position in a chair, with the furrowed face of someone who was in serious pain. And when the doctor asked him that question about what's your pain level today, 0 being nothing, 10 being the worst pain you've ever had, he kind of gritted his teeth and he said, "Oh, it's about a 3." And obviously the doctor and us, we could see it wasn't a 3. It was much more than a 3. So in that case, we realized, okay, he has more pain than a 3. But there were also times where his pain, he was completely dissociated from it. So he was taken into the hospital a few times to try and take him off a bunch of heavy drugs and put him on a bunch of different heavy drugs to try and manage his pain. And his body would lie to him. So as soon as he got on the new drugs, the pain would disappear. And he'd say, "Oh, I feel great. This is wonderful." But it was really about, he was going to get out of the hospital as fast as humanly possible because he had institutional trauma and he did not want to stay in there any longer than necessary. So his brain actually fooled him and told him there was no pain. And as soon as we got home, he would be in a major pain crisis. So sometimes there's just this way of reporting things like pain and symptoms. Some people with trauma have an increased rate of symptoms or a decreased rate of symptoms. And I always mention the social determinants of health. So, my husband came from a background of poverty. He lived in Northern Ontario where primary care was not great. He came from a family that was impacted by mental health issues, indigeneity. Three of his siblings are Indigenous. And he had and his cancer, his family is full of cancer. So he had lots of social determinants of health that sort of led him to be a person who was ended up quite ill at the end of his life, unfortunately. Um, and then in the interactions and communications with others, sometimes people's trauma can manifest that way. In Michael, it was distrust. So he always started with staff from a position of distrust, like they have to prove themselves. And he wasn't mean to them, but he was just very, very guarded. And I remember his first oncologist in his first cancer is a lovely man, very, very kind. And when we went home, Michael would be like, "Oh, I don't know if I trust him," and he really always started from this position of trust and had to kind of build his trust in people. Um, and sometimes, as I mentioned, there'd be withdrawal or avoidance or this unconscious lying or trying to say the right thing when questioned. So you might want to think about, are there signs of trauma in you or in a person that you love and care for as they're going through the healthcare system? I think sometimes it's helpful to just have a better sense of like, what are those things that are potentially areas of difficulty that we might want to problem solve around. Mm. Then here are just some suggestions. And again, I always mention I'm not a trauma expert, but I'm just sort of bringing what was helpful for us in our experiences. So for patients and care partners, I do this as well. I do a different list for oncology staff recommendations. But one of the things I think as a patient or care partner is that it's important, and most people know this, but take a trusted person with you whenever possible. You do not have to do this alone. And they, give them permission if it's helpful for you to speak for you or jump in if you need some help. And just know that you can ask for help. So my husband had no idea when he was first saying, I can't do this. He had no idea that he was even allowed to ask for help, that it was possible to make the treatment work differently. And I mean, in fairness, the reason it worked was because of his incredible bravery and fortitude. But at least we had some understanding with the staff, so they had some sense of what was happening. You can ask people to stop. You can ask them to slow down. Repeatedly, you can say, just wait. I think sometimes healthcare providers tend to give you a whole process when they describe it, but they don't kind of check in with you enough during the process when they're busy and rushing through things. Ask them to explain in more detail if you want to know what it looks like. To warn you if they're going to do something, to warn you if they're going to touch a certain part of you. And you don't have to disclose any personal information, but you can just say, please warn me before you touch my shoulder. And then ask that they ensure consent at all the different phases of things and check in with you. I'm going to need you to check in with me a few times. I'm nervous about this. Can you please check in with me several times? Your privacy should be preserved if you do disclose anything, but ask them, like, what does that look like for them? And then you might even want to call ahead to ask if they use trauma-informed care principles. I think a lot of healthcare services are starting to know about trauma-informed care, but it's not very widespread yet. And then don't feel that you need to disclose personal information or give details about things. As I said, Michael and he decided that he wanted to say that he was a child abuse survivor with a choking and smothering history so that they could really get a sense of what he was facing with the mask. But he could have just said, I have past trauma. I need help with this. He didn't have to give any sort of details. The other thing I would say too, though, is that messaging is not passed consistently from one practitioner to another. So I kind of wished that other people would know in the system, other doctors, other nurses, other people who were helping us, that they would have known that he had this issue but there was no like process for people transferring that information, which meant that it was up to us to problem solve it all the time. And so that's something I've talked to oncology practitioners about as well. is that you need systems that are going to help patients with this. And an electronic medical record is great, but people don't look at the EMR every time they go in to see a patient necessarily. So it's not a foolproof situation. As I said, don't think that you have to do this alone. There's help. There's help institutionally. You can ask for help from the doctor's office or healthcare facility. And as I mentioned, the information is probably not going to be shared between providers automatically. And then here are some like phrases that were just helpful for us. They are childhood abuse survivor or trauma survivor. We need your help to problem solve. We need your help, I think is a good phrase to know that you're allowed to use and it's your right to ask for it. Or I need to know exactly what will happen before we start. I need to feel in control. Please don't touch my X, Y, or Z, or warn me before you touch my, please avoid X or Y. Don't stand behind me. You know, there's all sorts of, please don't start taking my blood pressure or my vitals in the middle of the night without warning me with your voice first that you're there. And then you can always say, I need a break, or I need my support person. I need to see the door. I need to keep the door open. I need to keep the door shut. Like all that stuff is your right to ask for. And then you can also ask about how will this information be transported to or transmitted to appropriate parts of the team so that I don't have to disclose again, if that is your wish. And the other thing I always tell people is that there are, in a cancer center anyway, and in lots of healthcare institutions, there are embedded social workers that can help you with some of this. So as a care partner, I was extremely traumatized. I acquired trauma during Michael's cancers, watching him suffer so much, watching him suffer the cancers and watching him have all these things reactivated from his past and having to go through them anyway. And I needed help with that. I didn't have, he was somewhat okay, somewhat good at actually compartmentalizing. So we would leave his radiation appointment and I would be absolutely, devastated. And he sort of shut his brain off and had done what he needed to do after he left the treatment room. He'd wash his head and his shoulders and stuff and kind of recompose himself. And then he could just block it away. Whereas I had a lot more trouble with that because I hadn't been trained in an abusive situation as a child to kind of compartmentalize things. So I needed help with support, and there is support available, both in community settings and also in institutional settings. So that's a little bit about our challenging story. And I also wanted to mention, I guess, that Michael, who's pictured here, had challenges with his cancer journeys and his brain tumors, but he also was someone who had incredible fortitude and resiliency because of his past trauma. As I said, he managed it quite well, and he could always get back to the positive. And I remember the first day that he was fully paralyzed. I had been away while he was becoming paralyzed with COVID. I had quite a serious case of COVID, so I couldn't see him for 15 days while he was in the hospital, which was really awful. And he kept telling me, oh, I can't feel my left leg. I can't feel my right knee. Like it was creeping up his body. So when I got back, he was fully paralyzed. And I knew he was going to be fully paralyzed, but seeing it and knowing about it are two different things. And that first day, he said to me, I don't know how long I can do this for. And we both cried. And in about half an hour, he just said, okay, this is how it is now. And he accepted it and he moved on. And so he was able to really impact his own thinking and hope all the time. And he said to me the day before he died, there's always hope. He said that all the way along. There's always hope. He never gave up hope. But he also wrote me a love letter every day of our 25 years together, except for the last 3 weeks when he couldn't write anymore. And in one of his notes, he said this, which was really, I think, emblematic of who he was, and emblematic of people sometimes who have dealt with really difficult things in their past. Life has sometimes dealt me some lousy cards, but I always ended up with a pretty good hand. So there's some good news about trauma survivors as well, I think, that do not discount them. Do not discount their absolute survival instinct and ability to see through really difficult stuff. And then I just wanted to share a bit of encouraging feedback when I do these sessions for oncologists. I think practitioners, whether they're oncologists or neurologists or neurosurgeons or physicians, family physicians, they're really motivated by this and have told me that hearing about a particular patient experiences was really, really valuable to them. So I want to say I hope you're going to have great experiences with the people you interact with. And then I wrote an article for the Canadian Medical Association Journal about our experiences. And so it's possibly something helpful for you to share with physicians if they're wondering about, if they don't know much about this or you want to explain a little bit about it. So that link is here as well. And then, as I said, I just wanted to signpost a few possible resources if this has been difficult to talk about or hear about. Here's some support services that you might want to look into. I had a couple of questions that were submitted before the session. And one of them was, with 1/3 of Canadians being trauma survivors, is there currently any research into the connections between trauma and brain injury and or cancer? And I sort of touched on that earlier about that adverse childhood experiences research studies where they really do look at the connection between trauma and future illnesses, serious illnesses. And so, yes, there is research about that, and it does show a connection in some cases. And then the other question was, as a caregiver, I'd be interested to know if being the only support to a person with both brain cancer and a history of trauma can, over time, cause trauma to the caregiver. And I'm not an expert on this, and I don't know of research around it, although there might be, but I can certainly say from a personal perspective, I think the answer is yes. I think the answer is that you are acquiring trauma potentially. I certainly acquired trauma, and that's something that I'm working through and having to deal with to this day still. So I hope that you give yourself permission to seek out help for your own trauma too. Any other questions?
I think that's all that we had that had sort of come in prior. We had some comments here. I just want to say before we get into this, I'm so deeply sorry for your loss, Christine.
Thank you.
And we really appreciate you sharing such a personal experience with us. We had some really wonderful comments from the community who appreciated your presentation as well. Someone applauding you for your courage in speaking. We had another thanking you for your vulnerability. So we'll be sure to share all of those with you afterwards. But yes, thank you so much for being here with us today and for sharing the answer to those questions. We'll, again, make sure that we share all that with you afterwards.
Thank you very much for letting me share a little bit about my favorite person. It's a gift for me too.